meningitis, and the meninges. For my graduate project, I will be discussing the meninges, meningitis, and the associated changes in brain function. I will also touch on how this condition may impact patients seen within the realm of speech and language pathology. It is commonly known that the brain and spinal cord are critical structures to our bodies and the proper functioning of all that our bodies do, such as speaking, thinking, and muscle movements, to name a few of the many functions. In order to maintain proper functioning, the brain and spinal cord must be protected. The meninges do just that, as they are the protective tissues that cover the brain and spinal cord. Cerebrospinal fluid, or CSF, a fluid cushion for the brain and spinal cord, is also housed within the layer of the meninges. There are three membrane layers within the meninges: the dura mater, arachnoid matter, and pia mater. The dura mater, the outermost layer, as it lies closest to, and in some cases attached to, the skull. It is fittingly called tough mother in Latin, as the dura mater is rigid and tough. This layer separates the brain cavities into compartments and protects the brain from displacement. The middle layer of the meninges is the arachnoid matter, and it lays over the folds of the brain. Directly below the arachnoid matter is the arachnoid space, and it is obviously above the third layer of the meninges. This area is filled with cerebrospinal fluid. Not only does CSF run through this space, but so do all the cerebral arteries, veins, and cranial nerves. Below the arachnoid matter and the subarachnoid space lies the third and final layer of the meninges, the pia mater. The pia mater adheres closely to the brain. This layer fuses with the lining of the ventricles to form the choroid plexus, which produces the cerebrospinal fluid. Meningitis is an inflammation of the meninges. Symptoms include fever, sudden headache, vomiting, double vision, drowsiness, lethargy, sensitivity to bright light, stiff neck, and altered mental status. Anyone can develop meningitis, but those who already have compromised immune systems are at a much higher risk. The inflammation is caused by a bacterial or viral infection, but can also be caused by fungus, parasites, reaction to medications, certain types of cancer, or a traumatic brain injury. Viral meningitis is the most common form of meningitis and is usually caused by viruses that enter the body and multiply in the tissue. Influenza, HIV, genital herpes, mumps, and varicella zoster are some of the most common viruses that may cause viral meningitis. Bacterial meningitis is a rarer form of meningitis, but is also possibly deadly. Many different bacteria may cause this inflammation of the meninges, but it usually starts as an upper respiratory infection that eventually spreads to the brain via the bloodstream. Bacteria can also directly attack the meninges. Pneumococcal meningitis and meningococcal meningitis are two types of bacterial meningitis. Pneumococcal meningitis, which affects mostly children under 2, is the most common and serious form of meningitis with lasting neurological effects. The neurological effects of meningitis can be seen in patients through a variety of ways, including difficulties with higher level neurological and cognitive functioning, auditory function, and even can put them at a greater risk for developmental disorders. First, let's take a look at the effects of meningitis on those who contract it as a child. In the study, titled Children Infected with Meningitis Before 1 Year of Age, were at increased risk of disability at 5 years of age, conducted by Perlman, 1,584 children who had meningitis were compared with children without meningitis. The study did not specify the type of meningitis, but regardless did conclude that children who had developed meningitis were at a greater risk for health and developmental problems. The article stated that children who contracted meningitis before 1 had increased risk of severe or moderate disability, which was 15.6% of the children, and mild disability, which was 29% of the children. Children infected in the first month of life, opposed to just within the first year, had even greater health and developmental problems. The next study, Neurodevelopmental Outcomes of Infants with Viral Meningitis in the First 3 Months of Life by Baker et al., is an older study, but was the only study I could find that specifically looked at the effects of viral meningitis. The study observed subtle differences in language, specifically receptive language, which were noticeable by 3 years of age. The children were tested using a variety of assessment tools, including the REAL, PLS, and Peabody Picture Vocabulary Test. Scores were compared with those of a control group. Differences were evident in verbal comprehension and language processing. Even though the score differences were subtle, as the children grow older, the discrepancy gap may also continue to grow in comparison to their peers' abilities. Another study by Grimrold, Anderson, Tan, and Nolan looked at the outcomes of 12 years after bacterial meningitis. This study found that children 7 and 12 years after recovering from bacterial meningitis had residual neurological and auditory deficits. The subjects had more behavior difficulties at home and school in comparison to their control peers. Mildly decreased IQ and impaired ability to perform neuropsychological tasks were seen 12 years post-meningitis. Central auditory function and higher-level cognitive skills such as organization, problem-solving, verbal skills, fluency, and mental flexibility were among the greatest deficits noticed. Meningitis with onset during adulthood can also negatively affect cognitive and neurological function. According to this study, Cognitive Outcome in Adults After Bacterial Meningitis by Hoogman, Van de Beek, Wiesfeld, Degans, and Schmand, cognitive impairment was found in 32% of patients, and this proportion was similar for survivors of pneumococcal and meningococcal meningitis. Survivors of pneumococcal meningitis performed far worse on memory tasks and tended to be cognitively slower than survivors of meningococcal meningitis. A pattern was also noticed in which cognitive speed played the most important role in decreased cognitive function. The study showed that patients post-bacterial meningitis are at a high risk of cognitive impairment. Seeing that this study showed cognitive impairment in 1/3 of patients, patients will continue to have cognitive complaints after the acute phase of their disease. Merklenberg, Sittinger, Schweizer, and Mueller found many of the same findings as just discussed in the study by Hoogman et al. In their study titled Cognitive Outcomes After Bacterial Meningitis. Merklenbach et al. Looked at the long-term cognitive deficits in adult patients with previously diagnosed bacterial meningitis. While the study looked at the patients more so as a whole, including symptoms such as long-term depression, fatigue, and irritability, it also describes patients' cognitive deficits. Patients at their follow-up examinations documented decreased speed of cognitive and psychomotor performance, decreased visual memory, reduction in visio-constructive capacity, diminished nonverbal and logical memory, and impaired associated learning. These symptoms are all indicative of a cognitive impairment. As just described from research, meningitis, regardless of the type, whether it be viral or bacterial, can negatively impact brain function and thus negatively impact communication. To recap, let's look at a list of the deficits in which may be caused by meningitis. Cognitive deficits, which include concentration, memory loss, difficulty retaining information, decreased cognitive processing speed, poor executive functioning, difficulty with organization and planning, low IQ, language impairment, mental deterioration, brain damage, hearing problems, deafness, speech difficulties, poor behavior, impaired learning. All of these deficits listed above may be contributors to difficulties with communication, whether that be with speech, language, or cognition. And luckily, we as SLPs are equipped with the knowledge to help patients in these areas. Whether patients are just recovering from meningitis or dealing with the residual effects of meningitis years ago, they can benefit from treatment with an SLP to improve their communication, whether that be learning compensatory strategies for organization, planning, and concentration, or therapy to improve their language skills. As the research stated previously, children who experience meningitis before the age of 3 months may have subtle differences in verbal comprehension and language processing. Even though the gap in comparison with their peers may be small in receptive language, the differences may continue to grow more noticeable over time. SLPs can most certainly provide early intervention for these kids to help boost their language skills. So, as we've discussed, meningitis can have devastating effects on one's brain, not just physically, but also cognitively and with language and thinking skills. While many may return completely back to normal after the onset of meningitis, others may have lasting effects in which the SLP can help to improve their speech, language, and cognitive skills. Here is a list of the references and resources used throughout my presentation. Thank you.